Hi, my name is Ashley Cravo, and I did my project on ADHD/ADD in children. History of ADHD/ADD. In 1902, a British pediatrician, Sir George Frederick Still, noticed in a lecture series that a group of about 20 children seemed to be easily distracted and unable to pay attention for a long time. He also noted that the symptoms he was observing in this group of children were unrelated to intelligence or home environment and were more common in boys than in girls. Then in 1922, Alfred F. Treadgold suggests that these behavior patterns were a result of physiology rather than just character flaws or a lack of discipline. This suggestion reported the idea that symptoms of ADHD were a result of brain activity within an individual. In 1936, the FDA approved Benzedrine as a medicine that could be used for the treatment of this condition. Then in 1937, Dr. Charles Bradley gives Benzedrine to his patients in order to help treat severe headaches, but instead he discovered that Benzedrine improved other things as well, such as improved interest in school, academic performance, and it even helped decrease disruptive behavior in certain children. In 1955, new drugs started to become available in order to treat individuals with ADHD. As a result, experimentation with tranquilizers and stimulants started to occur. This increases the interest in trying to treat hyperactive and emotionally disturbed children with pharmaceuticals. Chlorpromazine is also suggested as a potential treatment for hyperactive children, but it doesn't become as popular as Benzedrine or Dexedrine. So in 1957, the condition we know today as ADHD was named hyperkinetic impulse disorder by three medical researchers, Morris Laffer, Eric Denhoff, and Gerald Solomons. Ritalin is also mentioned as a potential treatment for the condition. In 1961, Ritalin is FDA approved for use in children with behavior problems. In 1968, the second edition of the DSM is printed and includes hyperkinetic impulse disorder. The first symptoms of this condition are finally recognized by the American Psychiatric Association. In 1970, there's public concern about the abuse of stimulant drugs. As a result, Congress passes the Comprehensive Drug Abuse Prevention and Control Act and classified amphetamines and methylphenidate as Schedule III substances. This helped to limit the refills a patient can receive and the length an individual prescription can last for. In 1971, there were numerous individuals abusing stimulants across the United States. As a result, amphetamines and methylphenidate are reclassified as Schedule II drugs. During that year, Dr. Paul Wender also publishes a book that mentions how ADHD runs in families, which helps set the stage for genetic studies of ADHD. In addition, Dr. Leon Eisenberg and Keith Connors receive a grant from the NIMH to study methylphenidate. In 1975, media claims that stimulants are dangerous and shouldn't be used to treat a dubious diagnosis. Also in this year, Benjamin Feingold states that hyperactivity is a result of diet and not a brain condition. This caused a lot of public backlash against the idea of treating ADHD with stimulant medications. Then in 1978, Judith Rappaport, a researcher for the NIMH, discovered that stimulants have similar effects on children with or without hyperactivity or behavioral problems. Then in 1980, the third edition of the DSM is released, and the APA changes the name of hyperkinetic impulse disorder to attention deficit disorder. In 1987, a revised version of the DSM-3 was released. This version is released as DSM-3R. In this version, the subtypes of the condition are removed, and the condition is renamed attention deficit hyperactivity disorder. By 1991, diagnosis of ADHD had increased, and methylphenidate prescriptions reached 4 million, while amphetamine prescriptions reached 1.3 million. In 1994, the DSM-3R divided ADHD into three subtypes: predominantly inattentive type, predominantly hyperactive type, and a combined type of attention deficit hyperactivity disorder. In 2000, the American Academy of Pediatrics publishes clinical guidelines for the diagnosis of ADHD in children. In 2001, the AAP publishes treatment guidelines for children with ADHD. In 2002, the first non-stimulant medication, Strattera, is approved by the FDA to treat ADHD. In 2011, the AAP releases updated diagnosis and treatment guidelines. In 2013, DSM-5 is published and includes language changes for each of the diagnostic criteria for ADHD. The subtypes of ADHD are now referred to as presentations, and the condition can be described as mild, moderate, or severe. So before diagnosing a child with ADHD, there's things that have to be taken into consideration. One of the things that needs to be taken into consideration is whether the symptoms of inattention or hyperactivity or impulsivity has been a persistent pattern or interfering with the functioning or development of the child's life. Also, the symptoms have to be present prior to the age of 12, and several of these symptoms must be present in 2 or more settings. There also has to be clear evidence that the symptoms interfere or reduce the quality of social, academic, or occupational functioning. It's also important to consider that the symptoms do not occur exclusively during schizophrenia or another psychotic disorder and are not better explained by another mental disorder. In the DSM, under the inattention section, there's a few symptoms listed. The symptoms that are listed in the DSM are ones that I listed here. So one of the symptoms is a child or individual may fail to give close attention to details or make careless mistakes in schoolwork, at work, or during other activities. They may often have difficulty sustaining attention in tasks. They may not listen when spoken to directly. They may not follow through on instructions or fail to finish schoolwork, chores, or any other duties. They may also have difficulty organizing tasks and activities. They may avoid, dislike, or be reluctant to engage in tasks that require sustained mental effort. They may often lose things necessary for tasks or daily activities. They may become easily distracted by external stimuli or become forgetful in their daily life. Under the hyperactivity section, these are the symptoms listed in DSM. So some of the symptoms that need to be seen before diagnosing a child with ADHD is they have to often be fidgeting with their hands, their feet, or they may often be squirming in their seat. If they leave their seat in situations when remaining seated or expected, they may often run or like climb in situations where it is not appropriate. They may not be able to be engaged in leisure activities quietly. They may also present themselves as being on the go or acting as if they're driven by a motor. They may also talk excessively or blurt out an answer before a question has been completed. They may also have difficulty waiting their turn or interrupt or intrude on others. So in the DSM, there's also a possibility that there's a morbid situation, which means that the individual might present more than one diagnosis. For example, some people with ADHD might have oppositional defiant disorder. So it's important, like, as we go back to the main diagnosis criteria, it's said to take into consideration that the symptoms are not better explained by another mental disorder. But sometimes it is possible to have two diagnoses. So the main diagnosis that either ADHD is paired with or confused with are ones listed here, which includes oppositional defiant disorder, intermediate explosive disorder, other neurodevelopmental disorders, specific learning disorder, intellectual disability, autism spectrum disorder, reactive attachment disorders, depressive disorders, bipolar disorder, and disruptive mood regulation disorder. So in order to assess and diagnose ADHD, children take physical exams like hearing, eyesight to rule out any possible symptoms that may look like ADHD symptoms but really aren't. And after that they're done with that and that ruled out those possibilities, they go more onto like taking assessments that are more cognitive based. Also, some children may be part of interviews, and most interviews are conducted with children and their parents or teachers because they usually provide more useful data on like their behaviors in different settings. Also, rating scales are helpful in assessing and diagnosing a child with ADHD. These are like scales designed to assess the symptoms of ADHD in a child, and they're designed for the parents and teachers to take. And yeah. Okay. So the development and course of disease. So when it comes to the development and course of disease in ADHD, most parents say that they notice symptoms in their child as soon as they're a toddler. But the thing is, some of these symptoms are hard to distinguish from like normal behaviors because they're so young. So it's better to try to figure out whether those symptoms are more than just normal behaviors or possibly part of a diagnosis after 4 years of age. Also, most parents with children with ADHD say that in preschool, the most common noticeable symptom of ADHD is hyperactivity, but as their child starts to enter like elementary school years, attention becomes more prominent and impairing to their academic career. So when it comes to the course of ADHD, a good proportion of children diagnosed with ADHD often remain relatively impaired throughout their adulthood. So some of the symptoms may continue throughout their lifetime, but the good thing is, as they get older, it becomes easier to manage some of these symptoms. Prognosis. So the good thing with the prognosis of ADHD is that the prognosis is generally good as long as the child who's been diagnosed with ADHD starts treatment early on and has support throughout their treatment. So the thing with ADHD is that it is a long-term chronic condition, and about half of children diagnosed with ADHD will continue to experience symptoms of inattention or impulsivity throughout their lifetime. But like I said before, as they get older, it does become easier and easier, and the prognosis is definitely better if the child can get treatment right away as soon as the diagnosis is established. Because if ADHD goes untreated for a while, it can start to negatively affect the child's social and educational performance, and it could also damage their sense of self-esteem, because most children with ADHD don't really have as many friends and don't really flourish socially unless they work on it. So yeah, so the prognosis of ADHD is definitely good as long as a child gets treatment and has support and is reminded to and knows how to associate good behaviors with rewards and bad behaviors with consequences. So with ADHD, there are risk and prognosis factors. The main categories listed in the DSM are temperamental, environmental, genetic and physiological, and course modifiers. So for temperamental, the DSM stated that ADHD is associated with reduced behavioral inhibition, referral control or constraint, negative emotionality, or elevated novelty seeking. These traits may predispose some children to ADHD, but these traits are also not specific to the disorder. For environmental, the DSM stated that although most parents say that their child with ADHD experience low birth weight, this is not really something that is hand-to-hand with ADHD, but smoking during pregnancy is more correlated to the development of ADHD in a child. So overall, exposure to environmental toxicants put a child at greater risk for the potential development of ADHD. So when it comes to genetic and physiological factors, certain genes have been identified as a risk factor for the development of ADHD in children, but they are also not causal factors. However, certain things like metabolic abnormalities can be bigger influences on the development and progression of ADHD symptoms. As for course modifiers, family interaction patterns were mentioned, and the family interaction patterns in early childhood are stated to unlikely cause ADHD, but also they may influence the course of development of the symptoms of ADHD. So difficulties and the means of impairment. So these are the main difficulties that children with ADHD experience. They experience academic struggles, language disturbances, sleep problems, and social dysfunction. Most children with ADHD don't have as many friends as neurotypical children, and most children with ADHD also have problems sleeping at night. Most of them, the reason why, even though they might not have a specific learning disorder, but children with ADHD tend to lose motivation throughout their academics, so they may appear to be less academically capable. But they can still be like a genius, but because of that the motivation thing, like they start off motivated and then they start to lag off, it makes it difficult for them to strive academically. And also family disturbances. There's been reports that some children with ADHD become resented by even their parents sometimes, or their siblings. So it could definitely be a real difficulty for them. So there's a lot of treatment options for ADHD. The main one is pharmacological treatments. So this includes stimulant medications, non-stimulant medications, but most parents prefer to combine medication with any type of psychosocial or therapeutic treatments. This includes like behavioral parent training, behavioral therapy, cognitive behavioral interventions for children, social skills training. Also, school interventions have been recorded to be good as well. Behavioral contingency program is like when a teacher has like a point system, reward system, kind of like behavioral therapy, done in a school setting. So you reward good behavior and give consequences to bad behavior. Also, another treatment that isn't talked about a lot, but is actually really helpful, is exercise. Because when we exercise, our dopamine and neurotransmitters become increased, and those are actually like the neurotransmitters that are associated with causing ADHD symptoms. So in ADHD, a child will have less of those neurotransmitters than a neurotypical child. So when they exercise, those neurotransmitters are actually increasing, which makes symptoms of ADHD easier to manage. So I added a slide on behavioral therapy to kind of go over like the goals and the steps of how behavioral therapy works. So the first step is to set specific goals. This can be as easy as having a child learn to finish their homework in an hour or a specific time. Also, providing worth and consequences is pretty important because you want the child to eventually associate good behavior with good rewards. And even if it starts off as a tangible reward, it'll eventually become an intangible reward because, like, let's say they finally finish their homework, they become successful at completing that task. This will help them carry over to their academic career and hopefully have them strive and flourish academically. So also you have to continue using the rewards and consequences in order for behavioral therapy to work. And the key for behavioral therapy with ADHD children is to stay patient, because sometimes they're just not going to be into it. And there's just going to be rough times. But giving up on the child doesn't do them any favors, or doesn't do the parents any favors as well. So my case study, I did a case study on Colby, and I got this from a case study book actually. So I'm going to read this scenario real quick, and then I'll get right into the case conceptualization. So Colby, a 14-year-old teenager in the 9th grade, came to the clinic accompanied by his mother, Tina. The appointment had finally been booked after Tina found Colby's midterm report card crumpled in a garbage can. Not only was he failing one course, he was performing miserably across all subjects. When confronted, Colby lashed out at her, saying it was her fault, and ran out of the house. Tina admitted to running down the street after him, yelling like a maniac. It was at this point that she realized that things had gotten out of control and that she needed help with Colby. His academic performance and temper outbursts were getting worse and worse. Tina explained that she also felt less able to cope with circumstances lately due to her recent separation from her husband, Josh. Colby and his 7-year-old sister, Susie, continued to visit with their father every Wednesday and every second weekend. Okay, so the developmental history here. So Colby's mother, Tina, reported that she was under a lot of stress during her pregnancy due to marital conflicts, and she admitted to smoking and having an occasional drink during the pregnancy. So this, like I mentioned before in a previous slide, smoking is correlated to the potential development of ADHD in a child. So that could have been a reason why Colby developed a mental disorder like ADHD. So Colby's mother, Tina, also said that the first 3 months for him were very difficult because of a sensitive digestive system. But after switching over to formula, he did settle into a better routine, but he did have digestive problems still and poor sleep patterns. On occasion, Colby will still complain about stomach aches and has to stay home from school. And he also has difficulty both falling asleep and staying asleep. On many nights, Colby is still awake when Tina goes to bed, which is around midnight. So Tina's mother said that developmental milestones for him did achieve within normative expectations, with the exception that Colby started to read at a spontaneous level at 2 years of age, and his language skills also developed rapidly, and so did his conversational skills. Family backgrounds. So there's some family members in Colby's family that actually have a mental illness. Like, for example, Colby's maternal grandmother has always been an anxious woman who has many fears and who has been on medication for depression for a while. She also suffers from post-traumatic stress disorder due to violence within the home. Also, Kobe's maternal grandfather was a heavy drinker and often became aggressive and physically abusive to his wife and eldest son. Kobe's maternal grandfather also had Parkinson's disease and eventually died after a lengthy battle with Alzheimer's. And then Kobe's mom, Tina, herself is an anxious woman who was a witness to domestic violence. And then Tina has also mentioned a paternal uncle that they don't have any connections with anymore, but he also apparently had problems with alcohol and was also believed to have some psychotic features such as hallucinations or delusions. So the thing with Kobe's situation is that there was a previous marital separation due to his father's infidelities, but like about 8 years earlier, there was already problems going on. But um, his mother Tina found out that she was pregnant with Kobe's little sister, so they tried to reconcile the marriage despite his father's infidelities. So during the past year, both Kobe and his sister were exposed to many arguments and verbal accusations that happened between their parents. So the reason for referral is because Kobe lashed out at his mother for asking him for his report card and ran away. And he's also up most of the nights, making it difficult for him to even attend school at a regular time. He also has difficulty staying on task, and his academic performance has gotten worse, and so did his temper outbursts. He's also been more disorganized lately, and he hasn't been able to adjust to the situation involving his parents' divorce. So, case conceptualization. So my client's name is Colby Tyler. He is 14 years old. He is presenting concerns of temper outbursts, poor performance in school, impulsivity, lack of motivation, lack of focus, sleeping problems, trouble adjusting to change, easily distracted, difficulty sticking to a task. So the goals for therapy are management of emotions and impulsive actions, and improving academic performance through better concentration, also improving sleep patterns. Client strengths. So the good thing about Colby is that he has a mother who wants to see her son perform better in school and get a handle on his emotions. He is also able to see both parents. Also, the good thing with Colby is that he was able to express his ability to hyper-focus when he was interested in something like the gifted program or his computer games, and he can actually focus when he goes on for walks. Client liabilities include the fact that Colby has been having difficulties adapting to change, and ever since the divorce, his temper outbursts and academic performance have become worse. Okay, so the diagnosis I gave Colby was ADHD, and the symptoms that support diagnosis are listed here. So, but there also have been symptoms that I wasn't so sure of because it wasn't mentioned in the DSM list, like his hyper focus ability. Also, there's a possibility that he might have a dual diagnosis with oppositional defiant disorder, because oppositional defiant disorder is more like related to the fact that someone doesn't really want to do something just because someone tells them to do, kind of like someone of authority. And like based on reading the case study, it's obvious that Colby really has like this type of feeling towards the teachers that only know how to attack his low academic scores. But then there's this one teacher who actually says something nice about him, and he obviously prefers that teacher more. So I'd say there's a possibility of that. So there was an area that I was concerned about during the case study, and it was because his mother Tina mentioned that she believed that Colby was blaming himself for his parents' divorce. There was not enough evidence in the case study to really suggest that. I just think he's having some difficulty just adjusting in general, and his ADHD seemed to be something that he's been struggling with a while. So it's just gotten a little bit worse as all this was going on. But some areas of treatment that I would consider for Toby, his temper outbursts are definitely an area that needs to be improved. Maybe by like incorporating exercise and and to alleviate some of those temper outbursts and feeling of frustration can be a good way to help Kobe, and like maybe like kickboxing or just boxing in general. He also needs to improve his academics through better concentration. So I would say like a good idea is a behavioral therapy program or behavioral intervention program where there's rewards for good behavior and consequences for bad. So the treatment technique I decided to come up with, I'd call it, there's two parts to it. I call it, the first part, the individual therapy part, is called active therapy, and then the family therapy part is active with families. So the reason why I call it active therapy is because it's an intervention that goes about similar to a workout. So in the individual treatment, each session will be about 45 minutes, and depending on the weather, some sessions will be hosted outside. So I would start off the session by throwing a softball, asking general questions like, what's a good thing or bad thing that happened to you this week? Or how are you feeling today? Like describe the way you're feeling using emotions, not just using the words good or okay. This will represent the warm-up stage of a workout. Then we'll move on to our mantras for the day before rotating between activities. The purpose of the mantras is to start off the content of the session with a positive attitude. During each session, Kobe would repeat a powerful mantra 3 times out loud before moving on to the next part of the session. So the next part of the session will be all like the exercises, sets, and reps of a workout. This part of the session will include rotating between activities meant to help with organization and management skills. To make things interesting and more fun for Kobe, I will create puzzle-like games where he can learn to organize things in the order in which they should occur. For example, I'd give him a scenario of a disorganized routine and have him use his skills to organize it himself. Hopefully this will help him transition what he's learned into his own real-life situations. While rotating between organization/management activities, Kobe will have the opportunity to do 5 to 10 reps of any exercise between each therapeutic activity. I would incorporate this into the treatment plan because Kobe has stated that he feels better and more focused when he goes on walks on the golf course. The goal of this intervention is to keep the individual engaged while also learning new skills and techniques. For someone with ADHD, it can be difficult to pay attention or stay engaged. By alternating between the 8 activities, it can make things easier for the individual to cooperate and stay attentive throughout the sessions. Another thing I would try to incorporate is acting. It's similar to like drama therapy. I'll use this as a way for Kobe to express what he'd like to say to his dad or his mom after certain things happen. But rather than Kobe being impulsive about it, he'll be given a few minutes to think about it. Just in case he were to get distracted, a doodle book will be given to him so he's remaining intact with the activity while thinking about his responses. And then at the end of each session, you will have a cool down where the individual will either be asked to try a 5-minute mindfulness activity or reflect on their feelings of how the session went. But some of the mindfulness activities can include breathing techniques or stretching. So for the family treatment part, which is active with families, the family treatment is actually recommended to occur on a 2-to-1 ratio. So for every 2 individual sessions with Kobe, there should at least be 1 family session. I would like the father to come on because then the progress can be made in Kobe's and his father's parent-child relationship, but the younger sister is not required to come. So the sessions will take about 45 minutes, and in the beginning of each session, the family is also expected to repeat 1 mantra 3 times in unison. This will be like the warm-up. Then activities will involve drawing out their feelings. Real situations will be given, and the member or members of the family that is associated with the scenario will have to express their feelings to the situation by drawing an emotion. Following that, families will work both individually and together to either make the situation better or pick one to act out. To make it more interesting, printed copies of the scenario will be made with fill-in-the-blanks, and cutouts of words will be given to each member of the family in a plastic bag. The activity will be a timed activity, and after the time runs out, members will be asked to share. After the individual part of the activity is done, the family will either choose one of the fixed scenarios to act out or work together and create a new version of the scenario. The scenarios will be based on real-life situations that are happening in their lives. For example, one scenario can be at parent-teacher conferences. Josh and Tina were constantly exchanging cold stares at each other. Then, Kobe will draw an emotion that describes how he felt during the time. Then each member will be given a certain amount of time to work individually to make the situation better, and then they will come together as a group to either make a new scenario or act one of the already created scenarios out. Other activities that may take place in the family sessions may include writing letters to each other and expressing their true feelings, or learning and practicing new communication skills, or also writing down a compliment about each other and what they would like to see change. At the end of each session, family members will participate in a bonding activity. This may include TV/movie charades, writing a positive message to each other, mirroring activities, short meditations, or a family craft. And these are my references. Thank you so much.